Good afternoon, colleagues. Welcome and thank you for joining our 9th CFSD National Clinical Pathways webinar. My name is Stuart Sutton. I'm a GP in Renfrewshire in GGC, but also here as a CFSD clinical lead for primary care, secondary care interface. The webinars are designed to showcase the pathways that have been developed by CFSD in collaboration with our clinical communities and a forum for education, informal discussion and Q&As. This webinar today is relating to gynecology with a focus on endometriosis and postmenopausal bleeding pathways. Little bit of housekeeping. If you have any questions and answers, if you could use the Q&A button, it's just next to the chat button. That allows us to keep track of the questions and either respond to the answers in the box or to save those to discuss at the end. It will be recorded and it'll be made available on the CFSD website. And at the end, if you want to ask a question, you can raise hands as an alternative. So at that point, I will hand over to Dr. Lucky Saraswat, consultant gynecologist and CFSD Gynaecology SDG clinical lead. Thank you.
Thank you, Stuart. So welcome everybody, and thank you for attending this webinar series of our endometriosis and PMB pathway. Thank you, Jeff. So as a part of CFSD, one of our work streams is designing pathways for high volume conditions. And the main purpose is to standardize care across all of Scotland and streamline transition from primary to secondary to tertiary care. And what we are here to discuss today is how we can work together and help each other. And there might be queries and infrastructure issues, and that's why we want to engage policymakers through these pathways so that services can be aligned all across Scotland. Next slide, please, Jeff. So I'm going to talk about the endometriosis pathway. It has been adopted from NICE guidelines. It is an integrated care pathway right from the time patient presents to primary care to the time when she's referred to secondary care and to tertiary care. Overall, the aim of the pathway is to provide a holistic approach to the patients and timely care for those who have the diagnosis of endometriosis and including those who are presenting with endometriosis-like symptoms. Next, please. So we all know about endometriosis. It is a chronic condition. It affects women from puberty to menopause. It's estimated to affect 1 in 10 people. So by women, I mean those assigned female sex at birth and those who identify as women. It depends on the estrogen, and that's why it's rare after menopause or before puberty. The classical symptoms are pelvic pain, painful periods, painful sex, and infertility. The main problem with endometriosis is it is difficult to diagnose. We need a keyhole surgery or a laparoscopy to confirm or exclude the diagnosis. Next, please. It is also a very complex condition, so it's not easy for clinicians to manage it as well. It can occur in various sites and various forms. The natural history is very poorly understood. The classification does not match symptoms, and we all know about asymptomatic endometriosis as well. Next, please. So the main clinical challenges we face is because are that endometriosis symptoms are not typical of endometriosis. They can overlap with multiple other conditions. And because it needs a laparoscopy to confirm or exclude the diagnosis, often what happens is a delayed diagnosis, and there can be misdiagnosis because symptoms can be very similar to pelvic inflammatory disease or IBS. And one of the priorities, therefore, is how to reduce delay in diagnosis. The other problem is the symptoms don't correlate with the stage of the disease. So when it comes to treatment, and that's especially in secondary care, it's difficult to know what is the best way to treat certain kinds of endometriosis. But last and not the least problem is that there isn't a cure. Even after medical and surgical treatment, endometriosis keeps coming back. And the priority is how to prevent or treat recurrence of endometriosis. Next, please. So you might have all seen this report, and there's one published after COVID as well. It takes 8 to 9 years from the time the first symptom occurs or the patient presents to the GP for endometriosis to be diagnosed. So one of the purposes of this pathway is to streamline care, reduce delay in diagnosis as well. Next, please. So this is just an example of what endometriosis can look like. And you can see all these three pictures look so different. The first one is peritoneal disease, where you can see these bluish reddish spots. This is superficial peritoneal endometriosis, which cannot be detected by ultrasound or MRI. So it can only be diagnosed conclusively by laparoscopy. The second one, you can see a cyst on the left, ovarian endometrioma. It is called as chocolate cyst because the fluid is chocolate colored. And the third one is deep endometriosis with bowel stuck to the back of the womb. Next, please. So we'll move to the pathway. And the journey starts when the patient first arrives to the GP. So when the patient comes with pelvic pain, painful periods, at that point in time, we do not know if that patient has endometriosis or not. And one of the problems that patients face is they feel they are not believed. So the purpose is to listen to them, acknowledge their symptoms, and validate them. So in primary care, if a woman, a premenopausal woman, attends with chronic pelvic pain, period pain, pain during intercourse, or cyclical pain when moving bowels or passing urine at the time of periods, along with infertility, it may be an indication of endometriosis. And what we want through this pathway, and as clinicians, what we want to do is acknowledge that and give them a diagnosis of suspected endometriosis. So next, please. So the initial assessment in primary care includes examination and investigations. Now, these people can be very sensitive and examinations can be very painful. So it's not always necessary to examine unless you think there's a big, large abdominal mass or something. So when the patient comes to the clinic, it is helpful if you ask them to keep a pain and symptom diary, especially in relationship to their menstruation. Offer examination, but it's not mandatory because some people won't be able to tolerate it. Consider an ultrasound scan. Now, ultrasound scan cannot diagnose endometriosis. However, it does help exclude other causes such as fibroids. It can, however, diagnose an endometrioma or ovarian cyst related to endometriosis. What NICE recommends that do not do pelvic MRI or CA125. For most primary care practitioners, it's not possible to often organize MRI anyway. And even if all examinations are now normal, we should still consider the possibility of endometriosis. At that point, what this pathway is suggesting is the GPs discuss the diagnosis of suspected endometriosis with the patient and provides them the information. There's a link here for the RCOG patient information leaflet, and there's also information on NHS Inform. With the caveat that in the future, if a laparoscopy is required, it's possible that sometimes it may not show up as endometriosis. But what patients want is a suspected diagnosis at least, and the symptoms to be validated. Next, please. So these are some of the points just to consider, which we're all aware of, that endometriosis is a long-term condition. It has a significant physical, psychological, social impact on patients. It impacts women in the most productive years of their life when they're going to school. Severe dysmenorrhea, such that they're missing school, is a very strong marker when they're trying to make a career. So the impact is very widespread, and that's what people want. They want to be listened and acknowledged. And it is okay to tell patients that suspected diagnosis is fine. We can still start treatment. That does not mean that you have to wait for laparoscopy. So we can use it as a working diagnosis. The other bit is to initiate treatments together. So while the treatment is initiated, pharmacological treatment, ultrasound, and referral, all this can go in parallel and not one after the other. And this will help reduce delay in diagnosis. When it comes to initial management, what NICE suggests is pain relief and a hormonal contraceptive of their choice, especially if women are not trying to get pregnant. So there are two things about endometriosis that we need to manage. One is disease modification, which we do through hormones or surgery, and pain management, which is through analgesics, and sometimes we need to involve the pain clinics as well. If fertility is a priority, then the options are limited because they cannot have hormonal treatment, and these people will have a separate referral pathway, but still the symptoms and diagnosis of suspected endometriosis needs to be acknowledged. Next, please. So the key question is when and where to refer. I think one of the issues that patients face sometimes is they feel they have been moving from one hormonal contraception to another. So they're having the pill, then the Mirena coil, then the depot injection. So in this pathway, we have clarified that if in 6 months' time, the hormonal treatment is not working, or the patient is unable to tolerate the side effects, or it is contraindicated for some reason, these people should be referred to secondary care. So that's for both severe disease, persistent disease, recurrent disease, symptoms that are not controlled. They can also be referred at the very first visit if there are pelvic signs of moderate to severe disease. And this includes in patients that can be examined, a mass in the vaginal fornix behind the cervix, a fixed retroverted uterus, or if ultrasound scan has shown an endometrioma. If there's signs of deep endometriosis on MRI, or if they've had a laparoscopy elsewhere, as people move from one GP practice to another, one town to another, then they can be directly referred to endometriosis service. For young people under 16, and endometriosis does occur in young teenage girls as well, usually hospitals or each health board would have some provision to deal with that. So in NHS Grampian, for example, we have pediatric and adolescent gynae service, but there would be an equivalent service and they should be referred on there. Next, please. So moving on to secondary care, it is about investigations and management in secondary care. Often a lot of things have already been done. They would have had a scan. It can often look as normal. We will obviously get history from them in secondary care about their symptoms. And if examination is suggestive of deep endometriosis, an MRI scan is performed. As previously said, the only way to confirm or exclude the diagnosis of endometriosis is by laparoscopy. So if a patient has already tried hormonal treatment, laparoscopy should be offered to them. These days, during laparoscopy, the motto is to see and treat. So if minimal, mild, and up to moderate disease is found, it can be treated at the same time. But the most important thing is that laparoscopy is performed by a person who is trained to recognize endometriosis, as endometriosis can look very different, as I showed you in the 3 pictures. Even the superficial peritoneal endometriosis can have various forms. So during diagnostic laparoscopy, it's important that a full survey, a full 360-degree survey of pelvis and abdomen is done. So looking for diaphragmatic endometriosis, and that would be a reason sometimes for referral to a tertiary center. So it should also be discussed with the patients that even after surgery, endometriosis can come back, and hormonal contraception is recommended to reduce recurrence unless she's trying to get pregnant. If endometriosis is not found, alternative treatments to manage pain should be considered, and referral to appropriate specialty if in case it's thought to be bowel related. Next, please. So this part of the pathway relates to people who are trying to get pregnant. If a patient is trying to get pregnant in the next 12 months, I think everyone knows we wouldn't be offering them hormonal treatments because all these hormonal treatments are contraceptive in nature. At the time of laparoscopy, they should be offered excision of endometriosis. At the moment, it also says ablation of endometriosis because there's not enough evidence to say whether excision is better than ablation or not. If there's a cyst, it should, however, be a cystectomy, removal of the cyst, rather than burning away the cyst. Now, when people are trying for a baby and if infertility is an issue, it is important to counsel them regarding the impact of surgery, especially on ovarian reserve when ovarian cystectomy is done, and a very small chance of losing an ovary, which could be a complication during surgery. If fertility is not a priority, then we've already discussed see and treat endometriosis, and it depends on the expertise of the surgeon. So in most hospitals, there would be a person who's interested in endometriosis, or more than one person, and they can minimal mild endometriosis should be able to be treated in most hospitals. For moderate to severe disease, there are 3 regional centres. There's Aberdeen, Glasgow, and Edinburgh. And when diseases involving bowel or bladder or ureters, these patients can be referred to these tertiary centres. These tertiary centres also have an MDT setup where the images are reviewed and appropriate plan for the patient is made. Some patients might go for hysterectomy because adenomyosis is commonly coexisting with endometriosis. Even while hysterectomy is being done, it's important that endometriosis is excised or treated at the same time. Next, please. So these are the referral criteria for tertiary endometriosis centers. And one of the reasons for doing that was because there's variable care depending on where the patient is. So this is a unified criteria, and this states that any complex or deep endometriosis involving bowel, bladder, or ureters, whether confirmed at laparoscopy or specialist imaging such as MRI or specialist transvaginal ultrasound scan, and in patients who are wishing surgical treatment, they should be referred to a tertiary center. Another criteria is extrapelvic endometriosis, such as diaphragm, thorax, or other sites. I think this might change over time. We have said BMI less than 35 because in the past, we were not offering surgery to patients with BMI over 35 due to risks associated with anesthetics, and we wanted them to lose weight. But now with robotic surgery, this criteria might change over time. Now, tertiary centers also provide lots of other services, such as pain services, joint endometriosis fertility services, working with colorectal surgeons. So if there are any doubts regarding complex endometriosis, advice can still be sought from tertiary endometriosis centers. Next, please. So these are some of the references and resources. These are links which you can click. It's nice guidelines for endometriosis and NHS Inform, which is useful for patients, and they can be signposted to it. Next, I think that's probably it. Thank you very much. So I'll pass it on to Jennifer.
Thanks, Lucky. Hi, everyone. Thanks for inviting me, Lucky, to talk to this pathway on postmenopausal bleeding. I'm a consultant gynaecologist in Glasgow Royal Infirmary and also a menopause specialist and chair of the Scottish Menopause Network. And we work together with the Women's Health Plan team in Scottish Government on the menopause goals of the Women's Health Plan. Thanks, Jeff. So we'll all know that it's really important to investigate postmenopausal bleeding because of the risk that this is presenting in women who have endometrial cancer. So 90% of endometrial cancers will present with postmenopausal bleeding, but actually only 10% of women with postmenopausal bleeding will have endometrial cancer. And we also know that there's been a massive increase in women being referred as urgent suspicion of cancer, which was appropriate for postmenopausal bleeding, but the increase in use of HRT has meant that there's been increase in numbers of women with bleeding and therefore increase in referrals to these pathways, such that in 2021 and 2022 there was a 43% increase in referrals. And so it was really important to develop pathways to separate out or risk stratify those women who were at increased risk of endometrial cancer, such as those women bleeding not on HRT, from those women who are bleeding on HRT, who have a less than 1% risk of endometrial cancer. And so I was involved in the UK-wide sort of multidisciplinary guideline, and we have here the CFSD pathways that we'll describe. So we'll first of all look at postmenopausal bleeding not on HRT, and then we'll look at the pathways for those women who are on HRT, which are a little bit more complex, but we'll hopefully break that down for you today. Thanks, Jeff. So looking at firstly at women who present with postmenopausal bleeding, those women who are not on HRT. Firstly, what does that mean? So postmenopausal bleeding is any bleeding in a woman who has not had a period for 1 year or more. They're not on any hormonal contraception or on HRT, and these are women with an intact uterus or cervix. You would be surprised at the women that are referred who have an absent uterus or cervix with postmenopausal bleeding. So it's important that we're assessing these women correctly. And you'll note that there's not an age limit on this, because of course there are women who are postmenopausal at very young ages, those women with premature ovarian insufficiency or early menopause. And so it's important to recognise that too. Thanks, Jeb. So what do we do when these women present to us? It's really important to understand the bleeding pattern, to obtain a full history and an appropriate examination. So examine their abdomen and their pelvis to exclude any masses in the abdomen or pelvis, and also to carry out an examination of the vulva, as well as an examination, a speculum examination of the vagina and the cervix to exclude local causes of the bleeding. And to arrange investigations where this may be relevant, including cervical screening if this is overdue, or any swabs if you feel that there may be a risk of infection. It's important to consider those women who have a history of tamoxifen use, particularly if they have current tamoxifen use, as these women have increased risks of hyperplasia and endometrial cancer, as you know, and they should be referred straight to secondary care as an urgent suspicion of cancer. You'll see just in a moment that some women can be referred for ultrasound scan prior or instead of referring straight to gynaecology as urgent suspicion of cancer. But because ultrasound images of the endometrium in women who are using tamoxifen are unreliable, because many will look thickened and some look quite cystic and abnormal, then these women should be referred straight to secondary care, because they will need hysteroscopy, because ultrasound is not particularly helpful in this group of women. About 80% of women on tamoxifen will have a thickened endometrium by 1 year of treatment. Thanks, Jeff. So if in your area, and this will vary from region to region, you can refer directly for transvaginal ultrasound to assess the endometrium, then you can do that in some areas. And certainly for us in Glasgow, we don't have the ability to refer to radiology just because of capacity in our radiology department. So these women would be referred straight to secondary care rather than through the radiology department for an ultrasound first, but that may be different in your area. And so if you are referring to radiology first, this would be a pelvic ultrasound, usually carried out by transvaginal scanning, because this gives us much more reliable images of the endometrium. And if the endometrium is less than 4 millimeters, in its maximum diameter on an AP measurement, then, and speculum examination is normal, then we can reassure these women. Many of these women will have either vaginal atrophy or may have endometritis. About 80% of women will have this, and so treating vaginal atrophy may resolve the bleeding. If the endometrium is more than 4 millimeters or is not measurable or seen clearly, then we should refer to secondary care, as these women should have endometrial assessment carried out either by blind endometrial biopsy, for example, by Papel sampling, or by hysteroscopy to actually visualize the endometrial cavity. But this is particularly important because if we're unable to view the entire endometrium, then we really should be carrying out a hysteroscopy to view that. And this may be in women, for example, who have obesity, or in women who have fibroids, and so we're unable to visualize the endometrium clearly. Thanks, Jeb. I think we can move on to the next slide. So yeah, if endometrium is more than 4 millimeters, then endometrial biopsy is appropriate. And whilst hysteroscopy is the gold standard, then endometrial biopsy can be carried out in the first instance, unless there is suspicion on the ultrasound of complex features of the endometrium, or if there's a suggestion of a polyp, in which case you would want to directly visualize the endometrium, as previously mentioned, with a hysteroscopy. And of course, those women who have a history of tamoxifen use. And then further treatment will depend on the biopsy results, but we're not looking into that at the moment. Thanks, Jeff. Okay, so hopefully that's pretty straightforward, but happy to take lots of questions at the end on that. But we'll move on to the slightly more complex pathway that is the women who have bleeding on HRT. So these women have a less than 1% chance of having endometrial cancer, and so they do not need to be referred directly on the urgent suspicion of cancer pathway, and they're broken down depending on risk factors and their clinical history into a red, amber or green pathway, and we're going to work backwards in that order because the red pathway is the most simple or straightforward. But again, these women will present to you describing bleeding that they're having on their HRT, and what we describe it as is unscheduled bleeding. So that is bleeding in women who should not be having any bleeding at all, so those women who are using continuous combined HRT, or unscheduled bleeding in sequential HRT is any bleeding that is in addition to their regular withdrawal bleed that they would be expected to have. And so it's important to take that history of the bleeding pattern again. It's also really important to take the history of their HRT preparation, and there are so many different preparations that there can often be confusion between what is a continuous combined preparation and what is a sequential preparation. And we do sometimes see women in our secondary care one-stop clinics who've been referred with postmenopausal bleeding on HRT when in fact they've been on a sequential preparation and bleeding is entirely expected. So understanding what preparation they're on is important. You'll come to see in the pathway that how long they've been using it is really important in trying to risk stratify these women, but also understanding whether they're using it appropriately. Are they remembering to take their progestogen, for example, because sometimes they forget, and this is particularly problematic now where we're providing women more with separate preparations. When I first started doing the menopause clinic, more women than not would use a combined preparation, but now there's a much increased use of separate preparations, in particular a huge increased use of estrogen gel and Nutrogestan, but we can talk about that a bit more later on. And so understanding whether they're remembering to use their preparations. There's been a particular problem with the Everel Sequi patches, for example, because sometimes women don't understand that there are different patches within that box, and so they'll use them in the wrong order, and that will of course cause unscheduled bleeding. And so explaining to women how to use the particular preparation that they're given is really important. And then of course, like the women who are not using HRT, offering an abdominal and pelvic examination, looking at the vulva, vagina and cervix to exclude local causes, checking their BMI, because we know that BMI is one of the biggest factors leading to increased risk of endometrial cancer, and any investigations where that's relevant. But particularly relevant to this group are these risk factors. And so this is important for this risk stratification into either the red or amber or green pathways. And the minor risk factors include things like your BMI, so over 30 but under 39. Have they been using unopposed estrogen? And a minor risk factor would be if they've been doing that for less than 3 months, but more than 3 months, but less than 6 months. Tricycling HRT, which is where women will use estrogen all the time, but just use progestogen for a few days every 3 months or so. We don't see this an awful lot, but some women who find that they're particularly progestogen sensitive may choose to do this, but this increases their risk of endometrial cancer. And so if they've been doing this for more than 6 months, but less than 12 months, then that is considered a minor risk factor. The number of days of sequential progestogen also impacts their risk. So women should be using norethisterone or medroxyprogesterone acetate for more than 10 days per month, or micronized progestogen or progesterone, for more than 12 days per month. And so if they've been using fewer days of those various preparations for more than 6 months but less than 12 months, then that is also considered to be a minor risk factor, because that is inadequate progestogen use, as is using an inappropriate dose of progestogen for the dose of estrogen, and we'll see a table on that later on, but I'm sure you've probably already seen that within the document. And those women who are at increased risk because of anovulatory cycles or diabetes, which causes increased estrogen. In diabetes, it's because of increased circulating insulin levels, and insulin-like growth factor has an impact on the endometrium, but also reduces sex hormone binding globulin and therefore increases the free estrogen. And so that's where that increases that risk. And then it's very similar risks for the major risk factors, but for some of them just for a longer period of time. But one of the main risk factors, as we know, is BMI. So if your BMI is over 40, you increase your risk of endometrial cancer tenfold. And I don't think women know this, and some are quite shocked when we tell them that and discuss weight management. Lynch or Cowden syndrome can increase your risk 30-ish% depending on the condition, and so understanding genetic predispositions is important. Estrogen-only HRT for more than 6 months is a major risk factor. Tricycling for more than 12 months is also a major risk factor. Prolonged sequential HRT use for more than 5 years in women over age 45 is also considered to be a major risk factor. And then the days of using the progestogens, if you've been using less than 10 days of norethistron or MPA for 12 months or less than 12 days of micronized progesterone for 12 months or more, these are considered to be major risk factors. Thanks, Jiv. So if you have 1 major or 3 minor risk factors, these women should be referred on the urgent suspicion of cancer pathway directly to secondary care, and that's because their risk is significant. So that's a relatively straightforward thing to do. If we're assessing their risk, we can just refer them straight to gynaecology and the one-stop clinic. Thanks, Jiv. So the AMBER pathway, again, relatively straightforward. So these are women who may have 2 minor risk factors, or if their bleeding is prolonged or heavy, irrespective of the interval since starting or changing their HRT. And we'll see where this is relevant in the green pathway, but it doesn't matter how long they've been using their HRT or how long it is since they've changed their HRT. If they have 2 minor risk factors or their bleeding is heavy, they should be referred for an urgent transvaginal ultrasound, and this should be within 6 weeks. And here they will have their endometrium measured and obviously the rest of their pelvis examined. But if the endometrium is more than 4 millimeters on continuous combined HRT, which is the same measurement you'll know as women who are not on HRT at all, but for sequential, because of that sequential nature of the endometrium changing in preparation for withdrawal bleed, this endometrium can be a little thicker, and so they're allowed up to 7 millimeters if they're on sequential HRT. If either of those measurements, depending on the type of HRT that they're on, is thicker or greater than that 4 or 7, then they should be referred on the urgent suspicion of cancer pathway to gynaecology. If their endometrium is within those limits, then we can reassure women that their risk of cancer is low and they can be offered HRT adjustments for 6 months. But if their bleeding increases, so i.e. if their bleeding is prolonged or heavy or changes, then we should refer them. Or if their bleeding persists after those 6 months of making changes to their HRT, then again, they should be referred to secondary care. Thanks, Jiv. So the green pathway is a little bit more complex, and I remember having to look at this quite a few times when we were developing the pathway. So these are women who have either no risk factors or only 1 minor risk factor. And so these women are really low risk, and the likelihood is that these women have bleeding because their HRT is inappropriate in some way. And so these women can be offered changes to their HRT to see whether their bleeding settles. So bleeding is hugely common, up to 38 to 40% of women who are starting HRT and within 6 months of starting their HRT will have bleeding. And bleeding is also really common after changing their HRT. So if their bleeding occurs within 6 months of starting HRT or 3 months of changing their HRT, we can offer adjustments in either the estrogen or the progestogen for 6 months. If the bleeding persists after making those adjustments, these women should have an urgent ultrasound within 6 weeks as per the previous pathway, or they can discuss stopping their HRT. If they decide to stop their HRT and their bleeding stops, you don't need to do any further investigations. The patient or woman may then wish to restart her HRT, in which case then bleeding may of course occur again, and so you can then make adjustments for up to 6 months. But if bleeding then persists, then again they should be offered an ultrasound within 6 weeks. And then the same cut-offs for the endometrium apply, and if they're greater than those cut-offs, urgent referral on the urgent suspicion of cancer pathway. If the bleeding occurs at any point after the first 6 months or after 3 months of changing an HRT, they should go directly to an urgent transvaginal scan within six weeks, with the same cut-offs of the endometrium as 4 or 7 millimeters, depending on whether it's sequential or continuous combined. And if those measurements are normal, then of course they can be reassured. But if the bleeding increases or persists after 6 months, then refer. So it's really those 6 months and 3 months that allow you some time, if it happens within that, to make some adjustments for up to 6 months. And then if bleeding persists, a further ultrasound. But if it happens beyond that, then an urgent ultrasound and then subsequent referral if required. Thanks, Jeff. So what do we do to adjust the HRT? So what I say to women is that we can either stop their HRT, we can either reduce their estrogen dose, or we can change or increase their progestogen dose. So it will depend on what they're using at the moment, and it will also depend on what their personal choice is. And so we discuss the options because there are lots of options. Many women are using micronized progesterone, which is a really weak inhibitor of the endometrium. And so if women are using that particular progestogen, then you may wish to discuss using a different progestogen because it will usually be better at controlling bleeding than Utrogestan. Of course, everybody should be offered the 52 milligram levonorgestrel IUD as one of the options. Not everybody will want to use that, but it's a very good option because we know it's one of the best ones for controlling bleeding. Oral preparations we used to use a lot more of. We use much more in the way of transdermal preparations now. Oral preparations we know achieve bleeding control much better compared to transdermal preparations. And so if there are no risk factors to using oral preparations, then we should offer those to women. And particularly in the perimenopausal group of women, and we're using HRT a lot more in perimenopause than we ever did when I first started the menopause clinic. And of course, by its nature, perimenopause is accompanied by irregular bleeding. And so in these women, if they have no contraindications to oral estrogens, then using an oral preparation would be a good option for them. And if they're under 50 and have no contraindications to the combined oral contraceptive pill, then using that as an option because that will give them really good bleeding control and may give them amenorrhea, allowing them a continuous combined effectively preparation in comparison to a sequential HRT. So that's also a really good option. And with options like Zoeli and Clara, although that's a bit more complex because it's sort of it's more got different doses throughout the month, but they both have estradiol, and so that's beneficial in comparison to ethanol estradiol. And of course, women should be offered vaginal estrogens if that's appropriate and may be required in addition to their systemic HRT. Thanks, Jeff. So these are the tables that I was talking about previously. So the first table is really understanding what the doses are of the different preparations that women may use. And this is really important actually in understanding and also discussing risk with women because we don't have good data on endometrial protection with standard progestogens that we use for high dose estrogens. And some women are being prescribed, or many more women are being prescribed high doses than they used to be. And also there is off-license prescribing of greater than the higher doses of estrogen, which means that we don't have any data on how safe the progestogen is for endometrial protection for these women. It's really important for women to know that. It's also really helpful, this table, if you're moving from one preparation to another, because women want to change their preparation, to understand then what's an equivalent patch, for example, to the gel that they were using. And so that's really helpful for that perspective. But if you see at the top of the table where it says ultra low dose, standard dose, etc., then that helps us choose the dose of progestogen that's appropriate so that we are opposing the estrogen appropriately and thereby reducing the risk of bleeding. And you'll see that the norethisterone is just a standard 5 milligram dose, but there are other norethisterone preparations that you could potentially use off license, and the British Menopause Society has some great resources that can be used when discussing different progestogens for women, although these are off license use, like Noriday or Slin for drospirenone. But we also have Nalvi now, which I don't think is on that table because it came out after the table was published. But great tables, and also really nice to show women so that they can understand actually 4 pumps of estrogen gel is a high dose. We have very little data on the progestogen and the safety of that, in particular micronized progesterone, which is often given alongside estrogen gel. We don't have good data beyond 5 years of use in terms of endometrial safety, and so women should be aware of this. Thanks, Jeff. So these are just the resources that you can access. So the full document of management of unscheduled bleeding on HRT, which is, I grant you, a really long document, but if you've got the time to read it, it is really useful, and it's got a fantastic flow diagram. But this is obviously been reproduced in a really nice and easy to use format on the pathways that we're describing this evening. I think that might be the end of my slides, Jeff.
Thanks so much. So a huge thank you to Lucky and Jennifer for those presentations and taking us through the national pathways. We've already got some questions in the Q&A section, which we'll go through now. Please feel free to add any more or to raise your hand if you'd prefer. I'm going to start at the bottom and work up, if that's okay. So the first question I've got at the bottom is from Catherine Fraser. So asking, waiting times to be seen at gynae are still very long and even longer for laparoscopy. Is there any additional funding for this? Which I appreciate sits somewhat out with maybe your ability to provide a national response, Lucky, but I'll let you have a go.
It's a very valid question, though, and it's $1 million question. So the waiting times are where they are, but they're not 9 years, and the delay in diagnosis is up to nine years. So I think every year government is providing some funding, which is a non-recurring funding that health boards can access to improve waiting times. And a lot of health boards have used to do them for waiting list initiatives, whether it's theatres or clinics, which has resulted in waiting times coming under 52 weeks now. Now, 52 weeks is still very long, but at one point we were talking about 2 years. So it is work in progress. And I think if there's a business case that can be put forward to the Scottish Government, that could be helpful for boards.
Thanks, Lucky. That was a comprehensive and diplomatic response, so I appreciate that. Thank you. I think your point about the delay being longer, much longer in terms of diagnosis is really helpful. It just shows there is kind of improvements we could make kind of earlier in that process. So that's fantastic. In terms of another waiting time question, what are the current waiting times for referrals to treatment for tertiary services for endometriosis?
So I think it is slightly variable across the 3 centres, but by making this strict criteria, everybody should be able to access these services if they need it. I can't provide you the exact waiting times, and they are variable and they're still long, but I think it's in the pathway, it's more about management and how best to manage these people. As long as it's acknowledged, they can still be discussed in MDTs at times, and advice can be given while waiting for surgery or review. But it is still quite long. I would say several weeks or within a year, I would hope.
Yeah, thank you very much. We've got a question around pain relief options. So what pain relief options would you recommend to women with suspected endometriosis who are planning pregnancy?
So this is again a tricky one. The ones who are trying to get pregnant, there are very few options for them. And most of the time, if they're taking pain relief during periods, so NICE has recommended, when you say paracetamol, people get angry. Paracetamol in combination with an NSAID, So different NSAIDs may be used. Some people may not be able to tolerate NSAIDs, so they may need some kind of analgesics from opioid families, such as dihydrocodeine, tramadol. But if it's anything more than that is needed, then we should involve pain management services. There's also a SIGN guideline, which is within the pathway about pain management that you can access. There isn't one kind of pain relief that is suitable for all patients. So it has to be individualized depending on what agrees with them or not. We certainly wouldn't give them neuromodulators if they're trying to get pregnant, such as amitriptyline or gabapentin. So only short-term analgesics, because they'll be ovulating, getting pregnant, and so neuromodulators can have an impact on pregnancy.
Brilliant. Thanks very much, Lucky. Last one, currently on endometriosis. If the MRI and laparoscopy are normal, what are the chances a woman will still have endometriosis? I think at which point would it be felt endometriosis sufficiently excluded and a conversation about functional chronic pelvic pain be considered?
So if a laparoscopy is performed by a person who is trained to look and diagnose endometriosis, I think we can confidently say that you do not have endometriosis and can talk about chronic pain management. However, what I have also seen is at some point somebody did not have endometriosis does not mean that 10 years later they can't develop endometriosis. And this is because the natural history of endometriosis is not fully understood. And sometimes people have found microscopic endometriosis in peritoneal biopsies. We do not advocate taking peritoneal biopsies because you can't tell where to take the biopsy from if everything is looking normal. But I think if you're reasonably confident in the laparoscopy, it is okay to initiate conversation about chronic pelvic pain and management.
Brilliant. Thank you so much, Lucky. Moving on, I think these are probably for you, Jennifer, just related to the PMB pathway. So I've got, with regards to the AMBER pathway, PMB on HRT, when we request transvaginal ultrasound scans via primary care, these are rejected and advised to refer to gynaecology. I think this is a GGC question, as you intimated. The question, should these scans be done or referred directly to gynaecology?
Thank you. Yeah, it's actually a more difficult question to answer at the moment because there are some changes ongoing. So previously I would have said, yes, radiology didn't have the capacity and so they should just all come to us in one stop. And so they were referred on the USOC pathway. We are about to start, in fact, it may have started at the beginning of this month, the WIDESI trial. So I didn't put any slides in about WIDESI, but WIDESI is a vaginal swab that picks up methylated DNA on PCR for endometrial cancer, and it's a risk stratifying test that has a really high sensitivity and specificity for endometrial cancer. And even in those women who have a positive swab that ultimately then don't have endometrial cancer, up to 50% of those women will have been found to have an ovarian cancer. So a really useful screening test. And so we're going to be piloting that in Glasgow. And there was a move also to pilot through another pathway women who would end up having an ultrasound before coming to gynaecology. But at the moment, I think if women are being referred in for ultrasound to the radiology department, I think they are still being told to refer into gynaecology. And then gynaecology will pick up that referral and put it into one of those other pathways if those pilots are up and running at the moment. But that's purely a radiology capacity issue.
Thank you. And I think the next question is on a similar vein, the NHS GGC ultrasound access question, which I think you've answered there, and just some discussions around some cluster work and clusters engaging with audits around cancer diagnoses. We've got another question. Are you not keen on micronized progesterones first line for HRT, given the endometrial protection risks outlined here, even when balanced with the VTE benefits?
So yes, maybe I will extrapolate slightly on or give some more detail on that. It's not that I'm not keen on it. I think that we we see many more women with bleeding on micronized progesterone. I think if it works really well for them and they're not bleeding, it's a great progestogen. There was the French E3N study that showed that progesterone and dydrogesterone didn't seem to increase the risk of breast cancer for up to 5 years of use. So if women are particularly worried about the risk of breast cancer, it may be a good progestogen to choose. The VTE risk profile, as you said, is very good. Also, it's got fantastic sleep benefits for women who have sleep disturbance because of its impact on GABA receptors. And so it can be really helpful from that perspective. So there are many benefits. And I think what needs to be done is, you know, Lucky's already mentioned, is we need to individualize care. So we need to have these discussions with women describing the risks and benefits and the pros and cons of all of these medications, and allow women to choose what's right for them. And, you know, what we have within these pathways is the ability to tweak things and change things as we need to if bleeding occurs, as long as women are low risk or, you know, we're following these pathways. So it's not that I'm against it. I think just be aware that compared to some of the other progestogens, it is a weak inhibitor of the endometrium. And so if women are bleeding, that may be why. Please consider all the other risks, etc. But also we have good data that this is a good endometrial protector, as in it does protect the endometrium. We've got good data for up to 5 years of use with low and standard dose estrogens. So we don't have sufficient data for higher dose estrogens. And so I think we need to just take all of that into consideration and make a balanced decision.
Thank you. I think that shows how complex this whole area is in terms of how individualized the practice needs to be. I'm going to move us up. We've got a really interesting question here. I'm seeing younger women aged 14 to 18 with heavy menstrual bleeding affecting quality of life, attending for a LNG IUD. Younger ones struggle with the 52 milligram as it's slightly bigger than the Kyleena. Would the Kyleena be a suitable option for management? I sometimes add the pop on top if required.
I guess that's for me, isn't it? So the evidence is not there about Kyleena or JDS, but there are lots of younger people who can't tolerate the big 52 microgram LNG IUS. So people have used it successfully, and POP on the top can be given. It also inhibits ovulation, so POPs, so they don't get ovulation pain as well, because some people can continue to get cyclical pain despite LNG IUS. So while there isn't evidence, it can, if it works, it can be tried, but it should be discussed with the patient. This is not really for your bleeding. It might help, but we don't have enough evidence.
Perfect. Thank you very much. Another question. Have you read I'm sure you will have done that. Have you read the BSGE BMUS guidance on ultrasound assessment of endometriosis? Suspect more ultrasound scans will raise suspicion of endometriosis.
Yes, I have. And also I'm a part of the BSG and the Center Committee. So there is increasing interest and in fact training for specialized ultrasound scan. And that's why we have modified our pathway, which says if the ultrasound scan, a specialist ultrasound scan shows deep endometriosis, patients can be referred directly to tertiary care center. So it's still in developing phase, and each endometriosis center now needs to have an ultrasound scan lead who has expertise in this area. But most people would not be looking for those specific signs at the moment. However, over time, this might become standard practice.
Thank you so much, Lucky. I think we've got one more question currently, unless any more come in, and that's on the chat side. We've got, which is a good question. For women presenting with postmenopausal bleeding on HRT and awaiting a transvaginal ultrasound scan, should they be advised to stop their HRT? And I guess an addendum to that, having had this conversation myself in the past couple of weeks, they may choose not to, I suppose. That's they may be advised to, but they may choose not to. But it'd be good to hear your thoughts on that.
Yeah, thank you. It's a great question. And actually it is, that question is in the BMS, BGC, you know, the big document, the big long one. That question is in there. So we offer that as an option to women, and I guess it's just that individualized care again. They may not wish to, but they then need to understand that if they were to be found to have hyperplasia or cancer, then that's an estrogen-driven condition, and so that may potentially worsen that, and it's just about having that discussion. So they don't have to, but they need to be aware of that.
Fantastic, thank you. I think we might have just had one more question, apologies, popped in there. So we've got, is there a role for blind endometrial biopsy for unscheduled bleeding on HRT prior to measuring endometrial thickness due to lack of access to this?
Yeah, gosh, it's interesting, isn't it? We had this discussion recently at the sort of menopause specialist group. I mean, ultrasound is so sensitive, and relatively speaking, compared to an endometrial biopsy, non-invasive, to put that in inverted commas. And I guess we may still miss some things on endometrial biopsy. So a full assessment of the endometrium with an ultrasound is really important, because we may not pick up things like polyps, even if we do a blind endometrial biopsy. So I think it's really important that we follow the pathways and arrange an ultrasound. But it's certainly been a topic of discussion, but not something that we should be doing at the moment, I would say. Unless Lucky wants to comment herself on that, but I think probably no.
And sorry, Lucky, you're going to come in.
Yeah, no, I actually agree with Jennifer, because ultrasound is relatively easy to do, and with hysteroscopies, you've heard lots of comments from patients. It's invasive, it's painful, and we do far too many unnecessary hysteroscopies too, I have to say. So I think currently with the sensitivity and specificity of ultrasound scan, we are okay. But I had put a question in the chat myself: how do you treat recurrent PMB? And if somebody continues to have recurrence, and even if endometrial biopsy is normal, then we would go for hysteroscopy, because recurrent ongoing bleeding is a sign that we need to check more thoroughly, and hysteroscopy would be the gold standard then.
Yeah,
absolutely. I've answered my own question, I'm sorry.
Yeah.
That was for you, Jennifer.
And I'm going to take Chair's privilege to ask a follow-up to that, I suppose. Sometimes, and certainly we've kind of seen this in practice, if people have had a full investigation, maybe up to and including a hysteroscopy, are then reassured and then represent to general practice 12, 18 months later with a further recurrence, does that do we then follow the same process all over again? I guess we have to start from square one, even though they've had those investigations, been reassured and restarted their HRT potentially.
Yeah, absolutely. A number of these women will have developed a polyp, for example. A quarter of women, even women not on HRT, will represent with bleeding, and many of those will have polyps. A small proportion of those will have developed hyperplasia or cancer, and I guess similarly for women on HRT. So we absolutely, do need to reinvestigate women and start at the beginning again. Yeah.
Fantastic.
So can I add something to that?
Sorry, Lucky.
Yes. So I mean, what the guidelines don't have, and we were looking for that to put into the pathways, how long do we wait? So on a standard, I say 9 to 12 months, because these are slow developing conditions, because you don't know if it's still HRT related or something new has developed, and that's why they're bleeding. But would you agree with that, Jennifer? What time frame should we have to reinvestigate?
Yeah, so I think from that, again, that longer document, the only timeframes that they gave that were in relation to that is if they've had a normal biopsy and they rebleed within 3 months, they should come and have a hysteroscopy if they haven't had one. Or if they've had a normal hysteroscopy, and then I think they can give up to 6 months, but it's really difficult, isn't it? Because actually then you could end up reinvestigating these women. And I think, these are conversations that are important to have. Regards to, should we really be continuing HRT? What are the benefits that this woman feels are outweighing the risks and the downsides of having to keep coming back for reinvestigation because bleeding is happening, and particularly women who maybe have fibroids. These can be really challenging because they can bleed a lot. It can make it really difficult to assess them at ultrasound. It's really difficult, but I agree there's not good guidance in terms of the timelines.
Thank you.
I think for GPs, it'll always make us feel better if there's any uncertainty among specialist colleagues about these. So I think it's always one where we can ask a friend and speak to our specialist colleagues for advice. That's fantastic. I think this will be our last question. We're about to run over, but I think we've had so many really interesting questions and discussions that I think it's been absolutely worth us coming to the end and maybe running over. So can continuous HRT be used in young people in their 40s who are amenorrheic for years secondary to an eating disorder, or I guess for any other reason having a very low body weight?
Yeah, absolutely. I think the only reason to use sequential HRT is if women are still having bleeding. So if there's amenorrhea for any reason, and that could be because they're using desogestrel or, you know, any other reason, then using continuous combined is absolutely appropriate, unless somebody wants a bleed. Some women choose to have a bleed and may choose to use sequential HRT, but if they are already amenorrheic, they can absolutely use continuous combined. Yeah.
Fantastic. Well, that brings us on to our final slide, and most importantly, to hugely thank Lucky and Jennifer for their time, expertise, and skill in delivering complicated subjects in manageable, bite-sized ways for our primary care colleagues, so thank you. I'd be grateful if anyone who's in attendance could follow the link to provide some feedback, please, for the session. That will really help us with developing future webinars. There's a link there to all of the previous webinars, so you can watch those back. Our next webinar will be coming up on Tuesday, the 25th of August. That's going to be urology, BPH and recurrent UTIs, and the registration page and QR code link are there. Also wanted to highlight the Right Decision service. So that's the platform that we're encouraging everybody to use to access the national guidelines, and many health boards are using as their one-stop shop for all health and care pathways. There's a link there to the bite-size webinars, and if you could follow that link or the QR code. And in the meantime, we will hopefully look forward to seeing you in August for our next webinar. Thank you very much.
Thank you.
Thank you.